Hi, everyone. Thank you for joining our analytics panel discussion. I know you've already heard from our head of our data science team, Nick Patridge, with an overview of some of the recent improvements that his team has made to our analytics solutions. And now here's a chance to hear from some of our clients about how they're using data to manage their practices. As most of you know, Matt Seefeld is our resident consultant on all things revenue cycle analytics and automation. So he's joined our panel today. Welcome, Matt.
Thanks, Ashley.
All right, and so let's just hear from our other panelists. Harry, Todd, would you like to introduce yourself, please?
Absolutely. So my name is Harry Bookman. I'm Chief Operating Officer here at Center for Urologic Care of Berks County, Pennsylvania. I've been here for a little over a year, and previous to this, I spent the last 18 years of my healthcare leadership career in hospital administration. And so coming into a medical practice and ambulatory surgery center and finding that all the systems and processes that you get to used to in big health systems, they just tend to not exist in smaller private practices. So, you know, having this ability with dashboard and some of the things that we've been able to do with MedEvolve to give us the insights and not just the data. I often say, you know, we're drowning in data, but we're really struggling for those insights and those helpful nuggets to be able to kind of chart our course as an organization. So this has been wonderful over the last 9 or so months, being able to have this partnership and get back to being able to make some of those insight-based decisions that I've become accustomed to in my career. So I'm happy to be here.
Wonderful.
My name is Todd Greer from Little Rock, Arkansas with Premier Gastro. Been in the medical field since college, almost going on 20 years now. Worked in academic settings, private practice settings, mostly orthopedics. In the academic setting, medicine setting, I was an internal auditor. Did internal rack audits before rack audits actually came to the hospital. Was a certified coder as well. So done that most of my career, but been here at Premier Gastro for a little over a year. Something new. GI docs are a little different than orthopedic surgeons, which is a blessing. Don't have to deal with the orthopedic surgeons anymore, but that's kind of me in a nutshell. So the everyday grind of analytics and building spreadsheets and all that good stuff.
Great. All right, well, let's dive into some questions here. And we'll just kind of go around the room here. So Harry, then Matt, then Todd. So what were you doing before you started using analytics at your practice?
Just the basic reporting and calculating, you know, days in AR and average length of time, work, you know, looking at that work distribution by billing specialist or coding specialist, and just using some basic rudimentary reports in the system and trying to cobble together all the different missing pieces that I believe you really need to have, looking at revenue cycle. That's workflow. That's how long it was in their work bucket or their task list before they touch it. Are you really coding all the denials or adjustments appropriately? Looking at your percentage of cash that you're actually collecting as a juxtaposed to your insurance contract. So there's a lot of things. I think we were in the right ballpark, but at the end of the day, private practices and small physician groups, they struggle. They don't have big teams. They don't have, you know, all the finance and accounting contract experts that you have in the health system. So every dime really matters. I think even more so here than in the big hospital settings, because you don't have access to safety net money and some of those other things, you know. So it's if you don't collect it, you don't have it to spend. And so having the revenue tool really helps shed some light on some of the things I think that were just hindering the organization for many years. And that even comes from streamlining workflows and who owned what part of the process. So we made some pretty fundamental changes and are really thrilled with what we've been able to do so far in the last few months, even despite the ongoing pandemic.
Yeah, yeah, go for it, Todd.
Well, I was just wanted to agree with him. You know, the workflow, the analytics allow you to, you know, like I said, we just don't have the personnel, especially during COVID. We're a brand new practice that just started with 7 physicians and a brand new AFC and a GI practice. And we used the help of MedEvolve and revenue cycle teams to take a look, because myself, I can get kind of paralyzed by analyzing things. And this allows me not to do that. When I'm able to see the big picture and the breakdown of, okay, what I need to look at this month, the adjustments, are they corrected, courtesy adjustments, are they write-offs, what kind of write-offs, and take a look at workflow. How many people, what's the volume each person is working? Are they working compared to MGMA standards? Are they working compared to AAPC standards? It allows you to look at it, hone in on what you need to, and then make decisions in a timely manner. Beforehand, like you said, Post-its or spreadsheets, you're spending all your day trying to build it, and then the next day trying to review it, and you're just wasting a lot of time.
Yeah, actually, you've heard me say this before. I started my career with a healthcare consulting firm, Stockcamp. That's his whole model was measure to improve. So even back then with Access databases, it was how can I create a scorecard that tells me a story relatively quickly. And we played in the hospital space. We were in the large academic medical centers where you could make big moves on bad debt, big moves on unavoidable denials with just better transparency, big moves on balance sheet improvement with the AR. As I progressed, as I left Stockcamp and went on to a couple of I won't name them, a couple of the final 4 consulting firms, I got thrown into pivot table hell, where I was spending my hard-earned education doing right clicks and drag and drops, only to identify a problem days later to then have to replicate that same thing the next month and the next month and the next month. So when I actually left the last firm and started Interpoint, which was my company, it was a workflow automation analytics company, I left because of that. I was like, I cannot, in good faith, go work with health systems and provider groups and spend all of this time and money, and by the way, bill them for that inefficient use of time and money, and not get the results we want. It's just not right. And so bringing answers to the surface is key for all of us. And it started really with our scorecard that I know you guys use. Is that was in April of 2018. We had nothing like that. I asked our VP of Rev Cycle so I got asked to take over revenue cycle by the board in April of 18. I asked our VP of Rev Cycle, I said, well, what do you use to see how we're doing on behalf of our clients? And she's like, we don't really have anything. And so, well, how do you know when we're not doing right by the client? Well, they call us. I'm like, wait, what? So, I mean, it wasn't even a problem. So I'm like, we had to build something that brought structured data to a presentation layer that in a few minutes, it could tell us a story, and that story may be bad, but at least we know where to focus. And if it's good, move on with 1,000 other things we've got on our plate.
Great. Okay, next question I have here for Harry is, I know you all touched on this in that last question, but how have advanced analytics changed the way that you make decisions at your practices?
Well, I think it brings back, we make data-driven decisions. And that was one of my big things coming in here was, I know we don't have the infrastructure, but to me, gut decisions just lead you in all kinds of astray. And I think that because one little thing is off and all of a sudden you've made a decision based on your historical knowledge or your feeling or your experience. And if you don't have all the information around you, you're really making very, very bad decisions. You have some big blind spots. So getting back to data-driven decisions where we can see who's working what, why are we not getting paid what we're supposed to be getting paid? Is it, are we dropping the bill clean the first time? Are we sending the right information? If we're seeing these things are asking for records, send them up front and get those things done so we can lower the days in AR. Are we capturing the revenue, looking at the benchmark? You're supposed to get like 94, 95% of your net collections. But unless you're looking at that, it's like, oh, well, we've collected a lot and we should write this off, or we'll do whatever with it and move on to the next thing. Or we need to hire somebody because we're really, really busy. Well, you can be busy, but are you efficient? And so this allowed us to do those things. I remember when I told the office manager who was here since the organization started what I was thinking about doing, and she said, why don't we just hire another person? Well, because it's not about good people. I think Deming said it right, a bad process will be a good person every single time. And so for me, bringing one more body into something that I wasn't sure was set up quite right, that we didn't have the line of sight that we needed, we didn't have the tools that we needed to say if we're doing a good job or not, I didn't feel really good about that. And so through this process, actually, we've been able to grow. We've hired new physicians. We've hired new nurse practitioners. We're busier than we've ever been. Even in spite of the pandemic, being able to do telehealth and some of the relaxed CMS rules where we can now do telemedicine we couldn't before. So it allows us to reach patients in a variety of different methods. But with this workflow tool, it makes sure that we're still getting the revenue the way that we're supposed to get it. which is enabling us to make all kinds of efficiency changes. And I think patients now also appreciate that we're getting the right amount billed up front. We're getting it reimbursed quickly. We're getting all those things out, so they just don't have endless statements month after month, waiting for somebody to say, oh, that wasn't quite right, or oh, we missed the modifier, or oh, we need to resubmit this. So we've heard nothing but good things from patients, and you tend not to hear good things from patients when it comes to billing, but we've had a lot of patients who've been with us for about 30 years or so, and just hearing those good things makes you feel that you've done the right thing, and not only hearing from your internal people that their work day is easy, they feel they know where they stand at all times versus looking through their task lists the way that we used to do it, or their sticky notes or their folder that they had on their desk, but having an automated tool that serves up to them exactly what they need to touch versus scrolling through all the claims that are still in process, appropriately so, has really even helped from a work satisfaction standpoint from the employees.
I tell you, I'm being a revenue cycle back guy in my old days, and kind of drilling down into the weeds. Net collection rate is a big deal of mine. Data service to date of entry is a big key indicator to me on your days in AR. How fast is the claim getting processed, getting put into the system, actually going to the insurance company, going through the clearinghouse and moving on forward, and it's a clean claim. How many clean claims are going out compared to front-end denials? Looking at those things, great over the last 6 months. I guess I've been here a little over a year, but the last 6 months we have an older doctor in the group. In GI practices, patients grow with the doctors, and the referring doctors that are older refer to the older gentleman. It's just, well, he's a busy doctor, but he doesn't make as much as the younger guys. His Medicare population is 12.7% higher than the other doctors. It's like he has to see 2 Medicare patients to get paid for the one guy, whether they're younger guys. And explain that to him, and he was like, no, that's not it. You're not collecting. Brought in analytics, showed him, oh, well, what can I do? We're trying to work out ways to get newer, or I guess your commercial payer patients in to see him compared to having those high volume Medicare, especially after the cuts. I just ran a report on showing what cuts they're going to have next year for GI. So those are things that are coming in handy right now.
Yeah, it's Todd. You struck something for me is taking away the emotion from those conversations with providers. I think of like the old adage of patient deductibles and param exchanges. I used to walk into board meetings with physicians, a lot of times orthopedic surgeons, by the way, that would say, before MedEvolve, I collected more money. And I'd say, well, that might be true. Why don't we look at a couple of things first? And, did you notice that your best payers have actually declined in terms of your revenue mix? So you're seeing less of good payers and more of bad payers, number one. Number two, did you notice you're not collecting patient deductible money prior to service, at point of service, or even after the service? Right. So that dollar that, we used to only rely on 5 cents on the dollar coming from the consumer. Now we're relying on 50 to 55 cents. You're not even getting. So, again, try to just save time on the emotional back and forth. And what you just talked about, Todd, which is, let's put an action plan in place. All right. So number one, we're going to make sure that we collect all patient debt that's already owed prior to the next time they want to schedule an appointment. So that's number one. Number two, we're going to estimate projected liability and collect at least a deposit on that. And number three, we got to start looking at our referral patterns. Do we need to look at certain zip codes and say, hey, I have better paying patients coming from these zip codes? Should we throw a billboard up? Should we go drop gift baskets off to some referrals up there? So you change instead of finger pointing, you change the strategy to actually building action plans that will then generate the outcome you want. And so I really can attest on that.
Absolutely. Our next question here is, which KPIs, key performance indicators, do you find most helpful? Harry?
Yeah, I think I touched upon that in the last, conversation. For me, it's really that percentage of net collections. That's just a big one, and making sure that if you're having write-offs, are they appropriate? Did we not do something we're supposed to do? are there codes that we have in our charge masters that just aren't paying, and why do we have them? I mean, Medicare changes sometimes some of the things that you do in urology, like urine dips and different things. Some companies don't like consult codes or things a certain way. So to me, that percentage of net revenue is really, really important. And days in AR is always great, but I think that Todd even talked about, and I love that one. How quickly are we getting the claims out the front door? I focus a little bit more on the clean pass rate the first time, but he's absolutely right. Are there any bottlenecks on the front end that's really prohibiting? If you don't start well, it's really going to be hard to finish if you're behind. So those are the ones we focus on most routinely.
Very good, Todd.
I kind of hit on it at the last question, the days in AR, but also on the scorecard, we have a lot of ancillary services, which the scorecard breaks down our ancillary services. And each month I can kind of look and predict and find trends. That's what I love focusing on as well is trend analysis. So I can kind of see, all right, doctor takes vacation this time every year, doctor's off on Fridays, and I can kind of take a look when he's screaming, why my collections go down 2 months, if days in AR is 38 days in AR and you take a 2-week vacation and it's eat what you treat practice, you're going to feel the hit in 2 months. And so over time, I can look and go, okay, here's 2008, here's 2019, here's January to December. So I take the KPI reports provided by MedEvolve and the scorecard, and then to them, I'm able to put it in a picture format. Our doctors don't like looking at a lot of numbers. So I make it into a pretty graph for them, and they see the colors, the reds, the yellows, the blacks, things that trigger their mind, and okay, what can I do? Todd, what are the answers? And it allows me to provide a solution.
Yeah, that you crack me up with the graphs. One of the things we're working on at our data science team now and into next year is more data visualizations that are canned data visualizations that come out of the gate in Power BI. Metrics wise, I mean, you guys touched on it. I do like looking now at the number of scheduled patients coming in and how much they already owe a practice. It's pretty interesting to see, for the people coming in December, January, February, it's a creative amount of money. I think it helps to dictate to the practice that, hey, you got to start collecting from patients before you see them again, right? And that's just running the business. It's the business of healthcare now. I think the other one that I like, obviously, I talked about payer mix. I think net collection rate, obviously, that's one of my favorites as well. I think looking at AR trending is important. When you start to look at the AR trend month to month, some folks call it waterfall, but be able to see, am I starting to have certain buckets for certain payers growing? And if so, do I need to put a tactical strategy in place to try to reduce that? I know for our revenue cycle clients like you, Todd, I mean, we're looking at that all the time. We're looking at trends in AR days, billing WIP. We're looking at these things to say, hey, do I got to put a SWAT team in place here for the next 14 to 21 days for PGA to get charge backlog resolved, to get coding backlog resolved, to get some of this Blue Cross AR moving, And again, if we didn't have real-time transparency, we couldn't hold our people accountable. I mean, I can, in 5 minutes every morning, I can look across all of my RCM clients, and Jamie Brown does not like that. She does like it because she has the same tools, but she knows that about 5:45 a.m. Pacific time, she may get a question, because I can see everything. There's no hiding, and it's important. And, for folks like you, Harry, that are using our workflow suite, you have a whole different ecosystem of data too you have access to, right? You can now see the actions your people are taking. You can see the status of the AR. You can see the outcomes that you're getting, and so, and even now with financial clearance starting to roll out next year, I mean, there's going to be even more ways to capture workflow information and bring that into your data analysis and say, hey, I have effective people or I don't have effective people. I need to make changes here or there. So, structured data, the more we can grab it, the more we can build KPIs out. The more we can start telling stories without a lot of data mining, the more we can start basing decisions on facts and not feelings, which is something that we're steadfast here at MedEvolve.
Absolutely. And I know you've touched on some of these questions already, but I'm going to go ahead and ask them. So how have analytics changed the conversations that you're having with your providers? Harry?
Yeah, Todd talked about taking the emotionality out of it And I think that providers, especially the ones who have been practicing for a while, they remember what they call the heyday of reimbursement or whatever that is. And I don't know when that was. It wasn't the last 20 years that I've been in healthcare. I don't remember a heyday of reimbursement. It seems every year struggle. Right. And every year you see insurance companies that are in Ben or years. Interestingly enough, even this year, record profits. So, so it's one of those things that taking the emotionality out of it and helping them understand what happens in the ebbs and flow of their business. And even helping them understand, hey, patients do change insurance year over year. So here's what your practice looks like today, and even some of those predictive analytics of here's what the trends look like, and if we don't do anything, what can we expect a reimbursement to be, 3, 6 months or a year from now, versus do we have to do something different, whether it's with marketing, whether it's with outreach, what have you. Or this is why when you hear up front the patients are saying, why do I have to pay to see my doctor? I never used to have to have insurance. Well, you have a $50 copay to see a specialist now. I'm sorry, I have to collect that. And if you don't, look what happens, to what you're getting it paid. Like you said, Matt, it used to be 5%. Now it's 30, 40, 50% of healthcare costs are owned by the consumer, especially if they're in their deductible window for the year. So those are things that are important. I know they don't like to hear anything other than, doc, everything's wonderful, just tell me your advice in the exam room. But this is why you're hearing those things. So it takes the emotionality out of it. I think even for the newer docs, it helps ground them in that mindset of, here's how we're going to start off on a really good foot, because coming out of fellowship, residency, they don't really get any business sense. They just, or coding or billing or note taking. They don't understand how everything they do impacts revenue. And if they hope to become a partner more than just an employed physician, these are the important things they're going to have to know. So for me, it sets them up for success right from the gate.
I agree totally, and taking the emotions with physician out of it. Showing when I first got here, I sat down in my first board meeting and said, I'd like to provide you next meeting with some KPI reports. And I had 3 doctors go, what are KPI reports? And I was like, oh my. I mean, my head about exploded. And I said, well, next board meeting, I'll show you, and kind of gave some details. But, you just hit on something. We're in the middle of recruiting physicians right now. And the KPI reports allowed us to hire 3 APNs in a pretty quick period. We have one coming on board in February. But the millennial physicians, I don't think they get it as much as that 40 and over physician that really wanted to go into private practice. Not, I'm a paycheck doctor and I want to go home. And we got a doctor coming on board in the end of December. And during the interview process, he sat down with me and I showed him KPI reports. And he was amazed. Oh my gosh, y'all really do that? You'll take care of my practice like this? I said, well, it's a team effort. I'm showing data to you on a monthly basis. I have a team behind me and I work with Jamie, and Jamie, I call her quite a bit. Hey, what's going on? But then I can present to the new physician and teach him. Allow me to be the teacher, So when he was, the doctor mentality, sometimes they don't want to hear it or they think they're right. But once you prove them and you show the data to them, and most of them are data driven, they're science-minded people. That's why they're in the field they are. They get it. So it allows that month-to-month basis or daily basis or weekly basis for some physicians that want to know, hey, what's going on each week, and I can try to run a report or look at the trend analysis over the past 3 months and say, okay, this is what you're doing. This is the changes we made. We need you to have 3 more new patients a day. GI, 90% of the patients have a procedure. So if you increase your new patient volume by 3 a day, look how much money you're going to make. So.
Yeah, I love that approach. I can look at this question from the standpoint of how it's changed. Analytics have changed the conversations with our clients, right? As I said 2 years ago, it would have been reactive. Todd would have been calling me saying, my revenue cycle is horrible, my cash is down, what do you got? What's wrong with you guys? And I would have been like, I don't know, Todd, let me go run a bunch of reports and go do pivot tables again, like I was doing back in 2005 and 2006. And now I can be ahead of it before Todd ever calls me. You know, I mean, that's not saying that, look, it's a people business. For those of you that heard me, I mean, I will say whether it's Todd's people in RevCycle or Harry, it's the folks you're hiring, or it's the people I hire in Arkansas and around. RevCycle people, you know, have to be managed, right? There's lots of other things going on that can impact quality and effectiveness and stuff like that. So it is still a people business. Mistakes are made. But it's how quickly you can identify those mistakes that really makes the change, right? And it's instead of making excuses, it's being proactive about what we've already done about it. And then it's using analytics real time, right, to measure, is it working or is it not? You know, if I see a 10-day charge lag for PGA, one, Jamie sees it, two, Craig sees it, right? Todd sees it, Bill sees it, right? So we're now under the gun that, hey, we've got complete radical honesty here. We've got complete integrity, accountability, and transparency. We're not trying to hide what we're doing here, because at the end of the day, my contracts are not getting any better. You know, my rates that we used to get like 5 years ago in terms of percentage of collections were probably twice what we get now. So not only do you have more money coming from the consumer, less money coming from insurance, and of that insurance money, we're getting less percent. Like, I have no choice but to be super, super efficient with my people in terms of how we manage revenue cycles. So again, you know, being able to change those conversations with our clients to say, hey, let's roll up our sleeves and figure out a better way to do this. You know, this also goes hand in hand with communication. You know, I know this is an analytics panel, but I'm just going to plug this in too, Ashley, that how we communicate with our clients is also important. You know, next year we're going to be rolling out task lists through workflow to our clients, right? Some are using it today for, you know, but we're going to roll that out mainstream next year. And so when we need something from a client, it's not going to be an email anymore or a smart sheet or a phone call. You know, it's going to be something that's trackable. It's going to be a way for us to see how long it's taking to get responses. What's the cash value that's being held up? You know, Todd, Harry, I want you guys to be able to go to your providers and say, oh, by the way, you have 15 outstanding quoting questions. That the net on that is $12,000, and the average age is 18 days. So just understand that because you're not responding, you're holding up this much money of your money, right? You know, and again, bringing real information to the surface to say, hey, I mean, you can still behave the way you want to behave, but we're tracking it now, you know, and that's going to be a big game changer too with analytics. It's analytics around workflow, analytics around revenue cycle metrics.
That's great.
Very good. Let's see, next question is, are there any examples that you can share of how you've used analytics to identify issues and implement changes in your practice?
So yeah, I think one of the first things was looking at all the denial codes and write-off codes and adjustment codes and how everybody was using things differently. So this gave us the opportunity to come back and say, here are the list of codes that are acceptable in workflow when you're making adjustments, and let's talk through some of these things. You know, and found that there were a few folks who were a little creative in the codes they were picking. It wasn't a timely filing, it was a contractual write-off. Well, yeah, it's in the contract that you have a timely filing time period. I get that, but it's timely filing because you didn't drop the claim in 90 days. Sorry, you know, and so the workflow automates those things, right? So that was huge. Holding, you know, like I said, pulling back the coverage, holding people accountable, getting everybody to talk the same lingo, because we're very specific about what bucket, what code you use. And then in the workflow, where are you with those things? Why are you bubbling up way more to your supervisor on your work list that, you know, biller A than the billing specialist B? Well, why are you twice as likely to elevate something? There's something you don't understand. So it really gave us the ability to help from an education standpoint. And what was happening previous was they were just working the ones they didn't want to work last. And then, you know, and that was the thing, or always asking for help last, and it was almost like you had to pull out of the fire every single time. So this really prioritizing by dollar amount, by length of time in the queue, and not letting them skip from one claim to the next. They had to work them in logical order, give us the ability to educate, to hold people accountable, to train, but also to make sure that we had the right core competencies in everybody we had in the department, and give us the ability to go out and look for a new person who brought something to the table that we didn't have before, and streamline workflow in a way that we wouldn't have been able to do without that level of insight.
The front-end denials is a big key area. Usually on the scorecard, I forgot exactly what page it's on. But the front-end denials, when I see it and I see it denied front-end denial for insurance ID that's wrong. I want to explode.
Yeah.
That's someone not taking the time, even though front office is a higher turnover than most of your back office positions. So what are we doing wrong? Is our front office supervisor not teaching as well? Are they not paying attention? Do we need to put them on probation? Is it where I reach out to Jamie and her team? Hey, can you guys set up a training online? So what are we doing? And then taking a look exactly what MedEvolve and with those reports, and then also with the physicians, even the new patient to total patient ratio. I'm a big key performance in there where over 30% of your patients need to be new patients. So when our doctors see that they're only seeing X amount of 20-something percentage of new patients a month of their total population of patients, and another doctor's at 32, and they see the dollar amount, okay, now we can make that change. And I kind of said in the last meeting, here's a good way that I was able to hire 3 APNs. Let's unload some of the follow-up visits to the APN, bill incident 2, or let them be their own provider. I don't want to get in an incident 2 audit. That scares the hell out of me. Excuse my language. But that allowed me to hire the APNs, move forward to allow them to have more new patients, which able to get procedures done. So working hand in hand, the front office, everything happens when they walk in the door. The co-pays, the co-insurance, the phone call before they walk in the door nowadays to collect that money. Are we going to do a payment plan? How long is the payment plan? So all the data together allows you to make very good decisions, hopefully very good decisions, some bad, but at least you have a trend or you have the history of data to back up what decisions you made, good or bad.
Yeah, the one thing that I'll say is that, this whole movement of data analytics the last 2 years has allowed us to really look at how we set up the practice management systems from the begin with, and also how we reassess different transaction codes that are being used to say, for example, write off AR. Are these being mapped to a contractual allowance code, like, for example, as a timely filing, right? And so making sure that the data is right and the mappings are right, which then drives much better reporting downstream. And that's something that we're going to continue to force. And that could be anything from insurance categorizations to the roll-ups of transaction codes, CPT categories. It's imperative to get those right. So a lot of this stuff we'll do, and Harry, I know we did some of this with you, is that as we install workflow, we realize, hey, we need to be more granular. Michelle, let's go get these things in place. And even on the financial clearance side, we're starting to implement financial clearance, and Todd, that's something we're just going to give you guys to use. If those appointment types aren't right, the visit reasons, all that stuff, needs to be nice and orderly to drive better analytics on the back end. And so it's been really important to look at that from our standpoint.
Great. Let's see. How have your analytic solutions helped during COVID, preparing for shutting down, predicting revenue changes, and anything? What are your thoughts there?
Well, I think, and something that Todd brought up about the APNs, we actually onboarded 2 advanced practice nurses in the middle of the pandemic in May. And this was a strategy coming in 2020 that we wanted to have, was able to find and recruit. And then when the pandemic started tightening up here and things started shutting down and they started pulling back on elective surgeries and closing surgery centers in Pennsylvania, it was, should we be doing this? And, why don't we hold off? And I said, well, listen, there's a lot of good reasons we should push forward with confidence. And here's some of them, right? The movement to telehealth, allowing us to see and touch patients in different ways than we were able to do previously with some of the CMS restrictions lifting, that we're going to have to do urgent cases and we have to do as much as we can as quickly as we can because, we don't have weeks to book out anymore because I don't know what's going to happen 6 weeks from now. I don't know what's going to happen 6 days from now with how frequent, the state of Pennsylvania was changing some of their restrictions on what you had to report and what you could do and what have you. So with this, it allowed us to get the APNs in and onboarded quickly. And actually, for the first time in the organization's history, all the APNs are actually putting money on the bottom line. before, they looked at them as they were nice to have, they were convenient, it was nice for patients, it took a little bit of backload, but they never looked at them like you talked about, Todd. How do we open up your schedule more? It was always, we'll fill me first and then fill the APN, versus fill them. We can always backfill you. We can always put patients up. But if the patient's expecting to see the doctor, you're not bumping them down to the APN the day of the appointment. You know, that there is some loyalty and some retention risk in doing that. So, you know, proud to say that we made that decision, brought the APNs in May. They've made a huge impact during COVID because we are able to do the telehealth, because the telehealth visits take longer. They're less efficient than seeing them in the office. Even from a staffing perspective, you know, one medical assistant could, you know, be putting meds in with a patient, another patient could be in the restroom, and one could be getting changed in the exam room, and they could keep the flow going between 2 or 3 different patients. On the phone, when you're doing the chart prep and things, it's one single service. And so everything takes longer. Doctors can't double book on the phone. They have to be, you know, things have to fall right in line. So if we won't have the advanced practice nurses, this would have been a very, very, even more so challenging time, because we couldn't serve the volume of patients we could without some of the creative scheduling we've done in the office. And COVID took our ability to do that away almost entirely for quite a few months. And now that we're back, we've continued with telehealth, and about half of our patient volume today is telehealth, because it's just safer. We don't want to have a spike. We don't want to have an outbreak in the office. We want to keep our patients safe and our providers safe. And the advanced practice nurses, because of proving it through the analytics tools, has been the key to having all that happen. I can't imagine where we'd be if we didn't make the decision, because we didn't have the information to go forward with confidence.
That's a great answer, and you know, kind of bouncing off that, with our CFO here, and you know, I have the everyday collections, charges and collections. Everything's based off of that. How do we look at things? How do we make changes? But then how they tie into her side, because we have to work together. And it allows me to especially during COVID, because our surgery center opened up a week before COVID hit. Wow. We had 25 nurses that we just hired that left their jobs to come here. And what are we going to do? Well, we kept them all. Luckily, they opened up elective surgeries a little bit quicker here in Arkansas, and we were allowed to get back. Now, we didn't have any history on that, but we did have the history of doctors doing procedures. So we tied that into what a facility payment would be, tied it into with the CFO and the financials of rent, of PPE supplies that now we're, you know, tell you how much month, you know, how much a month we're spending in PPEs. What are we going to do? So it all tied in together. And with these reports and that we get monthly, and the phone calls I get periodically between them of working with Jamie or Craig, or the situation that come up with Blue Cross Blue Shield of Arkansas 2 weeks ago that about gave me a heart attack, but we were able to get on it. I called the CFO of Blue Cross, and they deposited all the money into the account the day later. So, but that is a team effort on both MedEvolve and our part, and the banking part as well. Is that if we weren't on this daily, it would have been, we would probably be getting, you know, still talking about it now. But with the help of MedEvolve and what we did and working together, we were able to get it on, email Jamie and Craig and everyone else and saying the money's in the bank, let's post it, let's get it there. So we worked as a team. And I think with the analytics and everybody being on top of things, you're able to see small changes a lot better and a lot faster.
Yeah. Yeah, I couldn't agree more with both of you. You know, as a billing company, you know, COVID was not a good situation for us. You know, when the OR is shut down for you all, obviously that's downstream to us. And, you know, we actually built a lot of our forecasting algorithms were built out at the end of March, early April, so we could understand the rate of change of charges. You know, you started to see charges declining, going underneath 2019 levels. It was like, wow, that gap was widening and widening and widening. It's like, when will it ever come back? And, you know, it was solid half of March, April, May, June. It started to cross back over the line, and it's stayed steady above the 2019 line since then. But, you know, it's under, but now we're looking at it again saying, you know, are we starting to see a drop off in visits? I mean, I had a call this morning with Jamie, and that was the whole conversation. Is we're seeing a little drop off in surgeries already in November, the second half of November, and we're starting to see that trend in December. Now, what does that mean in terms of cash flow for us? Do I need to furlough people? Right? Is there enough supply of work to meet, or demand of work for me to put supply of people on it? Right? So we're having those conversations using real-time analytics to make sure that we stay relevant. And that's again, when you look at, even with pandemic aside, you know, being able to have real-time insights into forecasting and predictability to say, hey, this is what it looks like is going to happen. Let's make that move now, right? And we move it, you know, we make that move with a calculated risk, but we make the move based on good data, right? Good data and good intel. And then if we have to change, just like in battle, if something has to change, then we can change quickly. But we would have been in dire straits if we didn't have the transparency tools that we had. I wouldn't have known when to furlough folks in April. I would certainly not have known when to bring it back on in June, how many to bring back on. You know, if I bring back people, should it be charge entry coders? Should it be AR reps? Should it be billers? Should it be posters, right? Should it be RCM support staff, call center, and everything in between? So, you know, we're having to, I always say that, you know, we built these tools and solutions, whether it's workflow automation or analytics for MedEvolve, it works so well for us. We started rolling it out to our clients like you all. It's working so well for you. We're going to continue to do that mantra of R&D driven by things that make our revenue cycle more efficient. You know, and that's something that has been a big theme, I know, of this user group, this conference today. But data analytics, I mean, I think that, you know, when I look at R&D spend in 2021, especially the first half, it will be focused primarily on the transparency and analytic solutions, along with workflow automation build out. Besides that, you know, a lot of the things that we as a company thought about doing at the end of 2019, we've just moved off roadmap, some of which just disappeared altogether. And we want to be really, really good at analytics, transparency, workflow automation, and virtualization, virtual communication, virtual workforce. And then we're going to stick with that. And all those other cool things we had, we'll either find partners, you know, that have good solutions we'll integrate with, or we'll take the risk of not having them. So.
Very good. That was kind of all the questions that I had, but I just wanted to kind of open up and see if you have any other thoughts or comments that maybe we missed during the rest of the discussion here.
I think it's interesting going to the board meeting. I have one later tonight, that the doctors, the partners look forward to the insights that we talked about. You know, Todd said he talks about it helped with recruiting. The doctors are getting engaged and seeing them asking for those questions. Where were we at this month? Where they are, and not just what's our percentage of collections, whatever. But they like that we have that structure around it, and it's not just I had a piece of paper and I can do some math on it, and here's what the business is doing. But that level of insight gives them the confidence that they're making the right investments, the right decisions, whether it's around things like vacation time or hiring, or are we going to purchase a new CRM? That's on the discussion for tonight as well. We need to, and here's why. Not just because it makes sense and the one that we have is a little, you know, end of life or whatever that is, but here are the cases, and here's how we know from an analytics perspective why it's a really good investment, and here's going to be the payoff of it. You know, payoff period is not just, you know, what you depreciate on your books or how long the loan is for. The payoff period is, you know, are you generating more in cases because you have it, and that's adding to you know, the bottom line. So those types of discussions really started with us getting this handle on AR, and we wouldn't have been able to get there, you know, if it hadn't been for the workflow tool and the partnership with MedEvolve. So, you know, that really helped us change the organization and pivot in a way that was needed because of a lot of reasons, not just because it's 2020 and now we have a pandemic. But I think what a lot of physicians get comfortable doing is they've been practicing for a lot of years, and they're just really, really comfortable. They don't realize that, you know what, if you're not willing to pivot and change because of data and because of trends, you're going to be extinct, or you're going to wind up like a lot of doctors begrudgingly becoming employed because, you know, you can't know it all, and they just want to be physicians. And a lot of them try to take a business class or get an MBA, and they're trying to care for patients and trying to run the business, and all of a sudden it doesn't work really well. It leads a lot of frustration. And so for me, this was the springboard for which we were able to really help the organization that had been successful for over 30 years pivot, which was scary because they'd always been successful and they've always done really, really well. And to say we have to change almost everything in the business and here's why was scary for them. But the confidence came when we have the reports, we have the analytics, we're making data-driven decisions, and we have a path forward. So I couldn't imagine doing it without this type of platform. And to create it in-house, I would have had to hire 5 or 6 people and pull together a bunch of different solutions to try to get us anywhere close to what we have today.
I think, like I said, the doctors look forward to their packets. They call them their packets at board meeting, or a monthly packet. Todd, is the monthly packet ready? Yep, it's ready. I'll be handing it out later. I think what I've seen here and is the competition that is given, because we're transparent. The doctors see the other doctors' reports. And I tell you, our doctors come from a 47 doctor multi-specialty practice and left on their own. Well, and there's 7 of them. Well, dividing overhead by 40 or 50 something doctors, now dividing it by 7 is a little different story. So being transparent, showing these reports out in public to them, and it's lined up, and they're, Todd, what is he doing that I'm not doing? What is it? It is a eat what you treat practice, and our doctors, that's what it is. And some of these doctors that relied upon the large group to take it, hey, I don't have to practice this hard. Well, these analytics, this data shows that maybe those days are over. You're going to have to practice a little bit harder. And the competition I've seen over the last 8 or 9 months, and especially in some heated board meetings over after I hand out the packets, but it has allowed us to grow. Some of the doctors have charged more than they've ever have, seen more patients than they ever thought about. I have one that now works on Friday and never worked a Friday before, but he sees the value in it. And he sees it. I just pulled some numbers off of the AGA, American Gastroenterology Association website. We're going to lose, compared to 2019 numbers and going into 21, minus 10% in upper GI and lower GI procedures. They're going to pay an average of 10% less. Medicare. What are we going to do? So, those are changes that we got to make, and looking at the data has allowed me to do that with the physicians. The data I've got from MedEvolve was allowing me to put it in with AGA and to come up with some figures and to show them this is how much we're going to lose for doing the same amount of work. What are we going to do different?
Well, and you mentioned competition. I look at it more as co-opetition, right? They don't want to be last in the street, but they also know they're splitting overhead. So if the other doctors kick in more, my life gets easier too. So I think it's almost like I want to lead the pack, but I want you to run faster to keep up with me. I don't want to just pull ahead and yard you, because I got to carry your cost. So I think that's been kind of interesting to see some of that sharing of best practice and actually using it as a tool to facilitate those discussions, versus before it's like I'll tell them if they ask, but I'm not going to go out of my way to impart any wisdom. Right. But I think it definitely helps facilitate those conversations as far as what are you doing, what are you saying, how does that happen, taking the emotionality out of it, and even helping uncover some of those things, like why are you 5 days delayed in getting your notes in, right? Like that kills you. You're not getting it this month. You're already done with your revenue cycle. And they didn't understand that before. Well, I'll get them all done by the weekend. Well, hey, you know what? If you have them done same day, next day, I got the bill out, within 24 hours. So that really, really helps.
Right.
Good stuff.
All right. I really appreciate that you were all able to join in on this panel discussion. I think it was a very informative, and hopefully our audience did too. And I think we might have a little time for questions. So we'll just go ahead and open it up for questions now. Sorry, I had to turn on the audio. Looks like it's just going to be us for the live Q&A. So, I think we've covered a lot of content today. I don't see any questions that have come through the chat, but if anybody has any, by all means, enter them. We're here. And otherwise, Matt, would you just maybe want to talk about what's coming up as far as analytics and what you're seeing for 2021?
Sure, absolutely. First of all, I appreciate everyone's attention during this hour. Analytics obviously is near and dear to my heart. I've been around healthcare data analytics since early 2000s when I started my consulting career, and we relied on data to identify the areas that we needed to focus on in our consulting engagements, and then we needed a way to measure to improve off of that, right? I mean, is the work that we're doing working or not, right? So when I look at what we've done here at MedEvolve, it's really, analytics to me is about bringing answers to the surface, right? The days of data mining and having to go read month-end reports and, well, it takes 15 hours of time to get this report package together, et cetera, those days are over, right? I want to be able to look at a scorecard and in less than a minute over a cup of coffee, understand where I'm at. And so when I look at 2021, our focus is going to be using the AI, using machine learning to really push information to our clients. Push the why, the what is happening and the why it's happening. One of my aspirations towards the end of next year is to even start to look at being able to bring in some solution sets to the data. So imagine this is what's happening to your revenue cycle. Have you considered these things, right? And so that's where we want to take it. We want to work smarter, not harder. We want to make decisions based on facts, not feelings. And that's really become a part of our ethos here at MedEvolve. Now, a lot of the analytics that we derive from is coming from workflow automation, right? And so it's not just grabbing practice management data, it's grabbing the work that your people are doing along the revenue cycle, and it's bringing that into our data warehouse and making it presentable to everybody.
Great. It looks like Todd was able to join us. So, hi, Todd. How are you doing?
Hello. Sorry, I got caught up in another meeting.
No problem. I know we're getting towards the end of the day here. I was just saying we didn't actually have any questions that came through the chat, but I was just asking Matt, so I'll ask you the same thing. What have you thought about as far as goals for 2021 when it comes to analytics? Are you planning on doing anything new and different?
That's a yes. I am. I'm. This 2020, I guess 21. The out of pocket is something our practice has kind of neglected in a way because we started in 20. Some of the doctors had the personality that they really didn't want to go after the patients real hard in patients collection and I'm not saying we didn't collect over the counter. What I'm saying is, when they brought the patients over from their other practice and the new patients, they didn't want to be in the Little Rock areas. They were the ones that are money hungry. We built a new building and this and that. But it's something after the last scorecard. Matter of fact, I just sent an email back, some questions on looking at AR. Patient AR versus insurance AR. I like to keep them separated. I don't like them together. I want to see how the insurance companies are doing in insurance AR and then patients. It seems like you have a lot more control over insurance AR than you do on patient AR. Because if you don't collect it in-house or before the visit, statistics show that you're not going to collect it most of the time. So that's probably one thing that I want to go after with my team here. That I got a meeting set up next week with our clinic administrator and our in-house billing and collection folks to go over a tutorial and teaching for collection procedures for the first year for January and February. Now that we own our own facility, plus the professional side, the old tricks of the trades of holding claims and billing after the surgery center bills we can't do that. So we need to find ways to collect and make sure we're collecting the right amount and not having a whole bunch of refunds on the back end. So I'm really looking at patient collections.
It's interesting, Todd. I'm glad you brought that up. If I had kind of like my last hurrah message to everybody is, is deductible season is right around the corner. We know that. A lot of your patients have balances due already for services that have been rendered in the past. Please make sure that when you schedule those patients in January, February, March, that you collect not just what you expect them, to owe for that visit, but all the stuff they already owe you. You've heard from Health iPass today. We've got Instamed integrated, right? So there's great partner and technology out there to help grab that money, but it's your money and you've got to get it. I have this fear that with these visits, starting to see a slowdown in visits a little bit. I think a lot of people with the pandemic are pushing surgeries off to say April, May, maybe once they get the vaccine, et cetera, et cetera. So you're going to have some volume pressures that normally wouldn't be the case in the first quarter of 2021. You got to make up. You can't be doing bad debt write-offs at the same time, right? You got to collect that money. And if the patient's going to come see you again, they already owe you money, then that's their financial responsibility, and that's going to be key. So patient AR is not something to be to forget about right now.
Yeah,
definitely. All right. Any other final thoughts? I guess this is kind of the end of the conference, so
happy hour.
It's time for happy hour. Okay, I agree. Believe me. Okay, so I'm going to just kind of switch over to a transition screen, and then we will jump back on for happy hour. I still have to calculate some prizes here, so hopefully I'll have that for you in a few minutes. But we actually just got a question. Do you want to answer a question real quick?
Sure. I think I'm reading it. Is this NFC?
What is your procedure when insurance company overpays or pays twice? Do you reimburse insurance company immediately or wait until they request it?
Todd, I'm going to let you take that one.
When they request it.
Yeah.
Arkansas Blue Cross, that's probably the most we get to where they pay twice. A lot of times it's probably our carrier that most often, and they usually catch it because what they'll do is they'll pull it off an EOB on one of their next payment cycles, and we'll show it there. So it's almost type a lot of times when you refund the money or send it back, it goes to nowhere land. And then next thing you know, you're getting it deducted off an EOB 2 months later. So, now you're out twice the money, So a lot of times I wait on the insurance, and we call and make them aware, but we usually wait and let them take it back at a later date.
All right, great. I'm sure that answered the question there. And thank you everybody for participating. I really appreciate all the interactivity and, all the participation from everybody. So thanks, Matt and Todd, and we'll see you back in a few minutes.
All right, thanks, Ashley. Thanks, Todd.